Thank you for having me today. I'm Dr. Scott Schlesinger, a neurosurgeon in Little Rock, with many of you here I've worked with, and some I have not yet had the pleasure. I work with and started a group called Legacy Spine and Neurological Specialists. That is a multidisciplinary group. And our team started, I started 20 years ago, joining Ron Williams and Ray Jewett, originally the Arkansas Neurosurgery Group, but they have since retired, and we have changed our name to really honor the legacy of the path set by Dr. Williams and Dr. Jewett. For those of you who ever had the honor to work with them, they were truly outstanding neurosurgeons. So that's where the name came from, the history of us. And this is our current name of our neurosurgery division. We also have an outstanding neurologist who just happens to be my wife as well, Dr. Kelly Schlesinger, who's extremely excellent doctor of neurology. We, as part of our comprehensive team approach, we also started a MRI center called the Pavilion MRI, and all of our clinical affairs, other than the procedures, take place at a facility called Pavilion in the Park in Little Rock. It's for those of you who don't know it, it's a beautiful, serene, quiet facility that is a mixed-use building right off Cantrell, and it's truly a very relaxing and quiet, comfortable place to bring a patient, to be a patient, and to experience medical care. Our MRI is the newest MRI in the state. It's a 1.5 Tesla, and I truly believe that you're completely wasting your money and you're sacrificing quality to use anything such as an open MRI, when a 1.5 Tesla machine is the gold standard. Ours is unique in that it's the largest bore closed MRI, 1.5 Tesla on the market. It's the GE 70 centimeter. So we can hold a 500-pound patient. I know none of you see large patients in your care, but I do from time to time. Our largest bore magnet can hold not only a 500-pound patient, but also a claustrophobic patients do reasonably well, without sacrificing the quality that you get in an open MRI. You can get patient comfort, and also it's just a beautiful environment. You do not have to be a patient of ours. You can, those of you who need the best MRI, I think, in the state, feel free to call and schedule directly for anything: hips, shoulders, knees. Well, obviously, we specialize in spine and brain, but the MRI machine is capable of any procedure, any imaging, except hearts. I don't think we do hearts, but at any rate, we also have Freeway Surgery Center, which is our outpatient surgery center located at the Freeway building. Now, this is the motley crew of the gray-haired fellow, myself in the center, my wife to the right, and our newest partner, a surgery partner, Dr. Takagi, who unfortunately couldn't be here today. You may have met him yesterday. Dr. Takagi comes to us from Rush University in Chicago. He was born in Japan, but grew up in Chicago from age 5. Speaks perfect English when he talks. He's very quiet, but like Ron Williams, what he says is very astute. Dr. Takagi is fellowship trained in complex spine surgery after a normal neurosurgery residency in Chicago as well. So he brings a very specialized approach to minimally invasive as well. That's clearly the direction we've gone, which I'll cover in further detail. What is our approach at Legacy, what I'll call the neurospine philosophy? Well, first and foremost, those of you who know me or worked with Ron or worked with Ray know that our number one foundation is conservatism. We believe that you must approach everybody as conservatively as possible, using surgery if it's necessary only as a last resort. And when we do perform surgery when appropriate and the last resort has been reached, in the most minimally invasive type of operation that we can craft that has a reasonable chance of working. And that's really the definition of minimally invasive. To do a very small operation that has no chance of working is not what I'm talking about, because that'd be a waste of time and money. But the minimally invasive definition that I will use is a procedure or care plan that is the least invasive yet has a reasonable chance of working. Obviously, you can throw large amount of steel at a problem and titanium and screws in something that can be fixed much simpler with perhaps a physical therapy or a needle or a micro operation, and you can achieve the same result at the end, but that result could have been achieved with much less invasiveness. So that's the conservative philosophy I'm referring to in the care of the patient as well as the diagnosis. I've been in practice for 20 years, and Ron 20 years before me, and Ray an additional 10 or 15 before that. And in our 50 some odd years, we've ordered a grand total of 0. If you keep multiplying that by 100, you'll still get 0 discograms. Well, why would we? Are we dumb? Why don't we know how to order a discogram? Because it has no utility for the patient. There's no reason to subject a patient to a diagnostic test or a procedure that has no utility to their management and care. So I didn't say we've ordered 1 or 2, it's still 0 after 50 years. That's the kind of conservative philosophy you can expect for your patients, because that's what you would want for your family, and that's what you want for yourself, and that's the way we're going to manage your patient. The next point of our philosophy is we're coming towards and I'm speaking mainly about the spine. We also care for brain problems. You don't see a lot of acute brain injuries that you're going to come to my office. You're going to come to the ER with those, and you may find out about them after the fact. And we also deal with nerve injuries, carpal tunnel, ulnar neuropathies. So we deal with a wide variety of neurological problems. I'm focusing today's talk mainly on spinal issues. Well, the approach that we bring is the background of neurology and neurosurgery rather than a background of orthopedics or pain management towards your problem or rehab medicine. So our philosophy is different, our approach is different, and certainly our training and background is different. I want to think it's the best, but it's certainly different. We also, at our center and my philosophy and Dr. Takagi's, and I might add we have a new young partner starting in November from Cornell that has been well vetted out along the same philosophical backgrounds. I'm not going to hire anybody that doesn't have the same philosophy of conservative, straightforward, honest, and the utmost of integrity approach to caring for patients. So I do apologize for those of you who had long waits to see me, but I was just me for a number of years after Ron retired. I'm happy to report to all of you that with Dr. Takagi on board, we have his, number one, his very Japanese culture of being on time for everything. In fact, he's been a great influence on me to also be on time, but has enabled me to be much more on time by providing another physician that is an excellent doctor to help care for patients. And with the addition of Dr. Rubin in the fall, I think we'll be very well suited to provide very timely care for your patients in addition to the best care. So I think the shortcoming that some of you in the room I see have always been mad at me about, but have hopefully withstood the years to get what I hope is great care, we've solved that problem. For those adjusters who had to pay for that, I apologize. But I hope we saved you large sums of money by the best of conservative care. What I'm getting to next is the issue that you are all familiar with. It's the old treadmill, the wheel of once a patient gets trapped into with some physicians who will treat them forever and get nowhere. We'll call that the hamster mill, if you would, that frustrates everyone and gets patients addicted to narcotic medications and not working for long periods of time, if not forever. Well, we certainly try to avoid that for everyone's good, for society, for the patient, most importantly, because we are the patient advocate, and whether they know it or not, it is in their best interest not to get hooked on narcotics and not to be dragged along through many months and years of unnecessary treatment. So we have a strong philosophical belief against that mill, if you would. And the final of our philosophical points I wanted to share is the one I mentioned earlier, which is the less is more approach, and we'll expound upon that more. So now, focusing specifically on the injured worker. The injured worker is not as, the typical patient coming in has some differences. I try to approach a patient in the same way I'd approach any patient, in that I'm their advocate. But I also have responsibility to society, the system. There's a duty to care for the patient and do the very best we can for the patient, at the same time representing an interest they may not understand. That is, again, that they're not well off being hooked on narcotics and not being back into the work system. And the diagnosis and treatment philosophy has to be the same. It's conservative, patient advocate oriented diagnosis and treatment. What's a little unique is the non-injured worker, they want to be back to work typically as quickly as possible, whereas there are some injured workers who do not. And so it's a balancing act to represent the patient's interest and that of the society's need to and the system's need to return them to some capacity of work as quickly as possible. So that can be a challenge, but certainly we try to work together with case managers to come up with a solution that tries to keep everyone's best interest in mind. And the next issue, as you all well know, is the complex issue of causation that frequently arises in the injured worker. And again, as my role as a patient advocate, what I typically say, well, if the patient's history is accurate, and they truly had no sciatic pain before this injury, and now they do, well, then based upon that history, it seems that the cause of their problem. But there's no way to know unless you just happen to have an MRI the day before an injury and a day after. Other than that, you typically take the position, well, I'm going to tell you what the patient told me. Now, the problem often arises is sometimes the patient is not forthright, but that really is not, in my opinion, the role of the treating doctor to differentiate, but really the information gathered by the case manager and adjusters to try to figure out, well, they really have had 5 workman's comp claims for the same problem over the last 2 years, and yet the history to this doctor was they've never been injured before. There you have a discrepancy that you deal with, or you may ask me hypothetically, well, now if this patient truly had multiple injuries, what can you say to this causation? So you all know these questions, and we'll move forward now with, again, the last point is avoiding that dreaded hamster wheel. So what is my job? My job is to figure out what's wrong with the patient. There are many causes of pain. And assuming that they're truly injured and they're not malingering, which unfortunately sometimes exists, maybe even sometimes more often than not, but if we assume that the patient truly is hurting, which is the base assumption we all have to assume, now we got to try to figure out what is it from. Is it from a deep source such as the disc, nerve root, the muscles, the joints, the ligaments, some of the above or all of the above? And that's my job, to try to help figure out what is the cause of pain and what is the best way to treat it. There are numerous ways to treat pain, and the last of which probably needs to be an actual operation by a guy like me or any surgeon, but I truly believe that getting your injured worker into, at least into our clinic, where I believe we do have a philosophy of managing the overall patient, whether they need surgery or not. Early on, will save everybody, the patient, time, the workman's comp system, time and money, to get the most appropriate care quickest, to avoid months and years of potential unnecessary procedures, rhizotomies, injections, etc., that are, or potentially not appropriate or indicated, but certainly may be. And the thing that I feel makes our system, our clinic unique, is that we offer the complete package of physiotherapy, spinal injection procedures carried out properly under fluoroscopic guidance and under proper indications, and then certainly, if necessary, surgical intervention. If not, then we make finality. We make a ruling that we've done the appropriate treatment, it didn't work, now it's time to close this case and declare the patient at maximal medical improvement status. I show this just briefly, a picture of a fluoroscopically and guided injection. Let's see, and now this, I'm going to skip back and come back. This is what I see way too frequently across the state, is the patient says, yeah, I've had 2, 3, 4, 6 injections, and the doctor had me just bend over and I had a needle put in me, and this has no chance of helping the patient. So getting an injection doesn't mean that an injection, if appropriate, has a chance of working if it's not done properly. So you can throw a nice pass downfield, but if it's not caught, it's not caught. And so the injection route, if that is what is appropriate, needs to be done correctly. And blindly putting a needle in somebody's back without fluoroscopic guidance or without the experience of someone who's done a large number of properly performed injections has little chance of helping the patient, but has a chance of hurting the patient, whether it be from infection or whether it be from injury or whether it be from hematoma formation. You just have, and it's absolutely impossible for anyone to know, unless you happen to take the time as a case manager to go in the room and watch whoever's doing it do it, and have the experience to see the dye spread through the epidural space. You really have no way of knowing. You may have a clue if none of your patients get better, that perhaps they're not being administered. And I think there's no area of greater, probably falsely done injections than is the cervical spine, because it's so potentially dangerous. The difference between having the needle in the right place in the cervical epidural space versus in the muscle or in the ligaments or just barely beneath the skin, there's a fine line between done correctly with a chance of helping and done into a soft tissue that might make them feel better for a few days, because any steroid in the system will make somebody feel better, but the chances of efficacy of helping somebody with a herniated disc or radiculopathy is very low if it doesn't actually get into the epidural space. Again, it's very hard for anyone to know if they're not got the experience of knowing what it's supposed to look like and what it did look like. So that's a pitfall to avoid. And here's another one, is this, a lot of the gimmicks, the laser beam's going to cure people. I'm going to do laser surgery. I'm going to do innovative surgery but I'm not a surgeon. I'm a rehab physician, or I'm a pain management doctor, but I'm going to do surgery through a laser beam. Is complete shenanigans and has no chance of helping the patient. Let's see here. This is an example of the old mill I was talking about, and the one that you are all familiar with is people getting wrapped up in narcotic treatment and getting involved in that vicious cycle that's nearly impossible to get out of once started. And we avoid that at our center. to the best of our ability. So what do we do? Again, I believe in the minimally invasive approach to care. It's not just surgery, but to care. And I believe we've covered that. I think these slides got a little out of order. They did, so I'm going to come back to this one. But believe it or not, can you turn the light down for a minute? Is that possible?
I can try.
Okay. I don't know how easy that is to see, but that's a small Band-Aid. This is really supposed to be the last slide, but we'll come back to it as well. But this was a patient who ultimately failed all conservative care, had a spondylolisthesis with foraminal collapse, and this is one of my outpatient minimally invasive lumbar fusions. That patient had a lumbar fusion and went home the same day, and the incision's about the size of the white part of that Band-Aid. And it can and should be done this way. Can you turn the light on if it is, I mean, back to where it was anyway. As I said, that skipped ahead. Nicole McCain is our physical therapist that works with us. I wanted her to come today, but she's busy at work. She was here yesterday. Some of you may have met her. She is an excellent physical therapist and, again, is available for patients even outside of our practice if you desire to get to somebody with who I think is one of the most experienced spinal physical therapists. But she asked me to put in a couple of slides about our physical therapy philosophy. Again, we try to avoid surgery, but if we do perform surgery, Part B, or if we do injections, Part B of any patient's care needs to be the physical modalities, the strengthening of the spine, the improved posture, the improved flexibility. And this is something the patient should do the rest of their lives. But the best chance of it happening is to coordinate with a spinal trained physical therapist. So I won't get into great detail, but we do run a program including at the end of our treatment, those many of you are familiar with the MedX program, which is using equipment that isolates the muscles of that part of the spine and allows testing of the strength and flexibility of that specific region. And we try to then graduate them after objective testing and say, okay, well, you've had your treatment or you've had your surgery, and now you are at the end, and let's get you at the best you can be, and then it's your job to maintain that. Now, we try to get them back to light duty and progressive work the whole time if they're certainly willing. This is some more information about the MedX program. I want to digress for just a minute and again show one example. Now, I'm going to get off from injections and I'm going to show some examples about minimally invasive surgery, because again, if they need surgery and they failed conservative care, and again, it's a non-mill conservative care, because I believe if it's a problem that you've determined doesn't need surgery, then you outline a plan. We're going to treat you with physical therapy for a specified time. We'll try a series of 3 spinal epidurals, plus or minus facet injection protocol, and it's very specific. It's not something you do over and over and over again. If they don't respond, for instance, to the epidural injections, you think it's discogenic pain or what have you, but it's not surgical, then we can consider, if appropriate, facet injection treatment. And if they don't respond to the diagnostic facet injection block, the first one we do, then it's over. I mean, there's no reason to do another one or a rhizotomy or anything else, because they have failed step 1 of that protocol. So we have a finite period of time in which you attempt conservative care. Now, if they're appropriate candidate in the algorithm now to go on to surgery, then let's try to come up with the least invasive surgery. Now, there are people that I see with neck or lumbar problems that really are not appropriately managed conservatively, non-operatively, because of neurological deficit. You know, if they have a cervical disc herniation with spinal cord compression, then it's completely inappropriate. I wouldn't treat anybody that way, and we're certainly going to treat the injured worker the same way we're going to treat our family. Okay, so there are people we have to skip. So in that I didn't want to show you a bunch of algorithms and complex pathways. They're all in our heads, and we'll be happy to discuss them with you when you come with your patient or if you ask. But the algorithm is fairly straightforward. If they're a potential candidate for surgery, but they don't have a significant neurologic deficit, or they're not in just excruciating pain, we'll try the conservative pathway of 6 weeks, 8 weeks of epidurals and therapy and medical gabapentin, not narcotic. We try to keep the narcotics very limited, and the narcotics we try to use, as the lowest level of narcotic possible, such as Norco. What we don't want to do is get people on OxyContin and fentanyl patches or any of these drugs, and I rarely ever prescribe anything more than Norco, even in the post-op patient, to avoid that narcotic addiction problem that is so prevalent. And I think Dr. Aman, who I think talks after me, probably will address that in greater detail. He's truly a great expert in seeing how bad and prevalent that problem is of narcotic addiction, and I know all of you know in the room about it too. But if the path comes to needing surgery, so what is the least invasive surgical plan we can come up with? Well, first and foremost, all efforts should be made to come up with something that is the least that will have a chance of working, as I said. Microscopic, minimally invasive spinal surgery is certainly the future. I've been lucky enough to help pioneer some of the advances of this with some of the implant companies of how to deliver these sorts of operations through just a tiny opening. And why is that important? Well, number one, treating a patient outpatient at an ambulatory surgery center, if feasible, saves everybody in the system significant money on the front end and the back end. The front end savings is it's less expensive than the same operation significantly performed as a hospitalized patient, but they're also exposed to so rare, well, knock on wood, but the exposure to things that run up enormous cost and morbidity and even mortality is, exposure to things like MRSA. So we try to do everything we can to keep our patients out of the hospital setting whenever appropriate and feasible. So we gotta minimize that operation to one a patient can tolerate outpatient. So we gotta have less tissue destruction, smaller openings, less muscle dissection, less ligamentous disruption. Less is more. So we can deliver that same operation through a tiny portal using the microscope, using special training, and using special equipment to not only do just a microdiscectomy that I think is very common and most people are capable of doing, but doing micro decompression fusions through the same exact microdiscectomy operation approach. And it's absolutely not only possible, but it is, I think, that's the way I do all of mine, and I think in 5 to 10 years, it'll be the gold standard to which everyone should try to perform, because it's right for the patient. And it allows the patient to get up and about the same day, minimizing the risk of deep venous thrombosis, minimizing the risk of infection, pneumonias, etc., and much quicker return to their normal life, which is obviously good for the society and workman's comp system in the case of the injured worker. Now, this is an example of using a minimally invasive outpatient fusion type approach. I mean, we can do it inpatient if necessary, if the patient's condition is appropriate. Now, can you turn the light down again? I just want to show, we were dealing with at the top picture, a collapsed foramen and a spondylolisthesis. I guess I do not have a pointer, but it's the top left hand. That's an expandable T-lift device, which I'll show you more. The screws put in. And now on the right, you can see a completely reconstituted disc, and not only the disc, but the foramen. You can increase the light again now. Now, how is this possible? Well, it's possible through using spinal navigation, which is the computerized basically our robot, our robotic surgery applied to neurosurgery. Using the navigation, we run an intraoperative CAT scan essentially, input the data into a computer program, and then I don't have to see anything. I really can't because the hole is so small, but I'm able to do my decompression through a tiny portal. As everybody that, I mean, no one needs a fusion operation that doesn't have a pinched nerve, in my opinion. Now, you see many of it, discogenic, degenerative disc being at least attempted to be taken to the surgery for a fusion, getting a discogram. So I told you there's zero basis in the literature for that. And if I were an insurer of the workman's comp system, I would never pay for discogenic lumbar fusion. It has extremely low chance of helping anybody, but a very high chance of making them permanently disabled and permanently hooked on narcotics, et cetera. So I'm showing you cases that you have to do a decompression because you're there for a pinched nerve in the setting of someone that also has segmental instability. Because if all they have is a pinched nerve and they failed conservative care, they just need a decompression, a microdecompression, microdiscectomy. They don't need any fusion. So who needs a fusion? Only those patients who have a pinched nerve and segmental instability. And the 2 or 3 examples really I can think of and that you would see is somebody who's got a spondylolisthesis, which is the slip vertebra in a pinched nerve that failed to respond to conservative care. So if you decompress them without stabilizing the slippage, they're probably going to slip more, unless it's a very minimal slippage, okay? Number 2 that you're going to see is a patient who has a foraminal collapse, vertical foraminal collapse, because they've blown out a disc, the foramen has become vertically narrowed, like that first example I showed you. And not just a foraminal disc herniation, because if all they have is a disc herniation in the foramen, using a transforaminal microdiscectomy, you can fix that without a fusion. So just keep that in mind in case somebody's saying, well, we've got to do a fusion because there's a foraminal disc herniation. That's not true. So far, it's segmental instability from vertical height of the foramen collapsing. Number 2, spondylolisthesis. And the third reason that you would consider a fusion is if that patient's had multiple recurrent disc herniations at the same level. That would be the indirect evidence that that segment is just unstable. So I'm not talking about they had a herniated disc in 1995 and then in 2014. That wouldn't count. I would just do another, if they didn't get better conservatively for that recurrent herniated disc and sciatic pain, that'd be a case where I would just do a recurrent discectomy. But if they had a first herniation and had to have surgery because he failed conservative care 6 months ago, had another, or a year ago, had another one 6 months ago, and now again, I mean, there's a good chance that patient's better served with stabilization. And again, so those are the only 3 reasons. I would strongly advise against ever considering a lumbar fusion. Again, I get on my soapbox here because I keep seeing over and over patients who've had this single level or multi-level fusions for disc degeneration. 0 chance of helping. Okay, maybe 1 in a million chance of helping, but very low likelihood of helping. The other thing I can tell you is the need, and you may have seen this, I mean, the incidence frequency at which I find a patient who needs more than 1 level of ever fused, if they need any fused, is very rare. Maybe 1 out of 10 or 1 out of 20 people have 2 levels of spondylolisthesis or 2 levels of foraminal collapse. But all too often, I'll see somebody coming in that's either had or somebody's trying to do a L3 through S1 fusion for degenerated discs. I would strongly, again, suggest rejecting of that. And those of you who know me also will do independent medical evaluations. And one of the most amusing ones is when I get 2 doctors battling it out over which surgery this patient needs. Do they need a artificial lumbar disc or an A-lift or an X-lift or L3 through S1 fusion? And I look at them, you don't need anything. You need a course of physical therapy and get back to your life. But all of you have seen this, and I encourage you to be deeply aware about anybody wanting to do a fusion. Find out why. What are the indications? And there's got to be one of those 3, or it's not indicated. And you're better off getting a independent medical evaluation from a neurosurgeon that you have worked with, you know, and trust that will be both the patient advocate and impartial, but appropriate. And not just, oh, well, if that doctor said he needs it, okay, I guess he needs it. Well, that's not doing anybody any good for any doctor to just green stamp an IME or a second opinion, nor do you want to say something that's wrong to be adversarial. You want to say what you would want for your family. Okay, so getting back to the technology that allows the delivery of now we're going back to this patient needs a decompression fusion, and now we've got a special way to deliver. The most important part of a fusion operation is the inner body fusion, and there's zero reason. I've done a grand total of 0 A lifts, 0 X lifts, 0 artificial discs, and I can expound upon the reasons why it's completely unnecessary for any of the above. If somebody needs a lumbar fusion, the most appropriate, most minimally invasive, least morbidity, least mortality, least cost, and most efficacious is a appropriately performed TLIF operation, which is enabled by something like this. This is the device. You can put it in very small through a tiny hole. You click your gun, and it expands, and it lifts up that collapsed disc. Now, this isn't the only type product on the market, but this is the one I use. So you go from a collapse. If you turn that light down for a moment, please. You go from that collapsed disc I showed you earlier, that with the foramen being annihilated, that's that white hole right behind the TLIF device, is now normal again because that expanded TLIF device has reinstated the height to the same height as the one above it. Okay, let's just see. See if this will actually. Oh, this doesn't look like this is going to play. Let me see. Oh yeah, okay. So let's see. Oh, let me. Okay, so it does look like this is going to work. So I'm able to do this again through an incision no bigger than 2 fingers through a TLIF, and I'm able to do it because I can put in this device small into the disc space. If I tried to put in something that ended up 15 millimeters, well, I'd need an incision that's 4 inches long because it's got to be bigger than the device. So you put the device in small. This particular company's the Stax device, but this can go up to 15 millimeters from 7. So this is a beautiful technological advance that has helped make this possible. The second technological advance, and if you need to, you can turn the light up a little bit, that has made this feasible is the ability to put when you have to perform the pedicle screw operation, the ability to put them in a path that's opposite to the way everybody is trained to, and most everybody does, by going from outside to in. So you'll see a typical pedicle screw trajectory that is coming from out to in, and that makes you have to make an incision much bigger. It makes you have to strip muscles way off to get out lateral to the facet joints. Using the medial lateral approach that Nuvasive and I believe Medtronic and Spinewave, a couple companies have come out with, and this is some of the work that I've been helping develop, and it's really very exciting. This is the complete opposite. When radiologists see my CAT scans afterwards, whenever, or x-rays, post-op x-rays, they say, are you confused? I mean, your screws are going in a very strange path. Well, no, they're going in the path that requires the least invasive approach, and they have the same, if not greater, strength. So I show you that's what they look like. Turn the light down now. Again, so this is a typical incision. I showed you the Band-Aid on it, but it's little over 1 finger and able to do a spondylolisthesis TLIF with 4 pedicle screws at the outpatient center. And oh, good, I had it at the end too. And there is the Band-Aid technique. In addition to lower back problems, so obviously we treat cervical. This is a cervical disc herniation. And this is the T-lip, excuse me, not T-lip, this is the implant that I use, which is a titanium cage packed with bone graft and a device put on in a patient who had failed conservative care with intractable cervical radiculopathy. You can turn the light back up again, please. And just like in the lower back, the indications for cervical spine surgery are the same. You avoid surgery if at all possible. If they come in with significant neurologic disease that needs to be dealt with surgically, then you come up with the least invasive cervical surgery you can. Very rarely do you need to do more than one level. If you can treat them conservatively with appropriately done cervical epidural injections, even with significant cervical radiculopathy, a lot of people get better with a cervical epidural injection that's actually delivered into the epidural space, and gabapentin and physical therapy. So there's still a high chance of getting those patients better without surgery. But if that fails and you go forward with surgery, then you try to come up with the least invasive operation. What you never do, avoiding the mill, is you never operate on somebody for a bulging disc or degenerated disc or even herniated disc with just neck pain. There's no indication. It's got to be for neurologic reasons, just like in lower back surgery. It's got to be for radiculopathy. So if you have people saying, well, I'm going to do a L4, 5, L5, excuse me, C4, 5, 5, 6, 6, 7, they've got terrible neck pain, headaches, dizziness. I'm going to do, I got bulging discs. Well, that's great, but surgery is completely inappropriate. So the indications for surgery for the injured worker patient have to be the same that are in our textbook for any patient and our family member. I think I beat that horse pretty hard. I think you understand our philosophy, and it may differ from a lot. We also treat things like carpal tunnel syndrome, again, conservatively if possible, surgically if necessary. I think that is the end of the slideshow. I probably have, I guess, maybe 5 or 10 minutes to answer any questions that you all have. Yes, ma'am. Well, I'll be happy to. There's not a lot that can be done about a post-concussion syndrome. In fact, there's nothing that can be done about it. I guess the key thing is to make sure when somebody's had a head injury that there's not a structural problem. So, if they've not been properly worked up, I would get an MR or CAT scan and make sure they don't have a subdural hematoma or contusion of the brain. And assuming that's negative, then there really is no surgical or neurosurgical care. There's really not much in the way of conservative care. I guess the problem becomes, well, they're dizzy, they have headaches, they confused, what are we going to do for that patient? That's a tough one. You've asked probably the toughest question because it's got no good answer. If they are legitimately injured and you had a significant head injury, you can certainly get baseline neuropsych testing to see if they do have legitimate and real cognitive impairment that would put them at, some risk of causing problems for themselves or others if they were back in the work environment. And they, but as far as, and then if they do, I can't treat that, but there are neuropsychologists that could outline a treatment plan for a patient who did have a significant injury. Probably 8 out of 10, particularly if it's just a minor bump on the head and negative studies, they're probably not going to have anything wrong on neuropsych testing, and there's probably nothing that's going to need to be done at all to them. Reassurance, your headaches will get better. Sometimes, if people are complaining of headaches and dizziness, I might refer them to a neurologist to get medical management of those symptoms. But I think if they're reluctant to be willing to go back to work, I think at that point you're probably going to have to get, again, neuropsych testing, even though it's likely to be negative with a minor injury. Now, that's very different than somebody that fell 15 feet, landed on their head, had a temporal lobe injury. I mean, that's a different story. I think there's 2 types of head injuries that you probably see. Those with a significant head trauma and those with minor head trauma that have the complaints of continued ringing in the ears, headaches, dizziness. The former are easier to deal with. There's objective data. It's the latter that are a challenge that I'm guessing that you're asking about. And I will tell you that if the patient is refusing to, I just can't work, whatever, then I think we'd be obligated to get them into a neuropsych testing and perhaps a functional capacity evaluation to determine, okay, well, there is no objective evidence of a neuropsych injury. Your imaging study is negative. The FCE says there's no objective limitation, so there's really, at that time, I would say everything that can be done has been done. You're at maximal medical improvement. You may have post-concussive symptoms the rest of your life, but this is as good as it gets. Yes, ma'am.
There's some information out there now that the steroid injections can lead to some bone deterioration.
Well, I certainly think, again, I want to tell you, I think that ties into the mill. I think if appropriately done with the focused algorithm of, we're not talking we're going to start epidural treatments today and carry this down for the next 3 years. I mean, I do not believe that giving a patient a series of 3 epidural injections, if you would, over a 6-week course is going to cause any deleterious effects if administered into the epidural space. I do believe strongly that getting into that mill of, okay, well, now we've done 3 epidurals, and now we're going to do 5-level facets on both sides, and then we're going to do rhizotomies, and then we're going to put a pain pump in, spinal cord stimulator, vagal nerve. I mean, I think that mill of destruction is terrible, and that includes the over-administration of steroid medication as well as narcotic medication. I think it starts a very dangerous path. I hope that answered the question, but I don't think if appropriately managed with a responsible way, I would take care of anybody, that there is any significant risk for short-term use of a steroid injection. I do absolutely think if it gets in the wrong hands that it's very dangerous. And you all probably seen people that, get no benefit at all. I think if they don't get benefit at all, and they're a legitimate patient, they probably didn't get into the epidural space, I think is a good chance of that, particularly with cervical epidurals. Cervical epidurals are so potentially dangerous to do right that I think that, if I didn't really know the anatomy like I know the anatomy in my sleep, if I didn't, I would err on the side of being too superficial, which helps the patient, much less, but has less chance of hurting the patient. But there's no need to do a procedure if you don't know how to do it right, because you want to do a procedure that has an acceptable risk, no matter what it is. Everything's got a risk. Everything we do, ACF, lumbar, anything's got a risk. But if done correctly and technically well and for appropriate indications, your hope is the benefit ratio outweighs the risk ratio. Oh, I hope that answers that question. Does anybody else have any questions of any kind? I'd be happy to answer either now or afterwards. If not, thank you all for coming and allowing me to come.